So now we are going to talk about nephritic syndrome. Okay, so in nephritic syndrome, what are the presentation? The presentation is oliguria, the hypertension, okay, weak immune status, okay. We are not going to say proteinuria because proteinuria can be a mild to moderate variant, but not a severe variant. Okay, sometimes it can be normal. It can be a normal. Okay. So, glomerulonephritis is a immunologically mediated disease. Okay, so immunologically mediated disease affecting the glomerulus of both the kidneys. So here we have the glomerulus. Okay, this is a tuft, okay, of arterioles. Now it can be immune complex mediated. Immune complex mediated means circulation immune complex or in situ immune complex. Okay, so immune complex means suppose there is a formation of antibody and antigen. This antigen antibody goes and binds to the basement membrane. There is proliferation, fibrosis, and that is known as immune complex mediated. Okay, number two, there is anti-glomerular basement membrane antibody mediated. That means there's a basement membrane, directly the antibody is directed to this basement membrane. Okay, so this is known as anti-glomerular basement membrane antibody. Okay, and there can be lymphokines mediated. Lymphokines or cytokines complement system acted upon this pathologic mechanism activate the secondary mechanisms that produce glomerular changes. Okay, now what are the different classification of glomerulonephritis? So number one is etiology. So what is the etiology? So etiology is, so what are the causes? Okay, so first of all, let's talk about the causes. In etiological classification, you have causative classification based on the identifier of the cause, and other one is the source of cause. Okay, so primary means unknown. So I'm unknown that how this nephritic syndrome has occurred. Secondary means the cause is known. Okay, now if the causes is known, what might be the cause? Okay, so it can be a microbial. Okay, microbial, or it can be a non-microbial. Okay, so certain bacteria are responsible, certain viruses are responsible, protozoa, parasite, fungus. So bacteria like group B streptococci is better you know strain 12 and 49. Group B streptococci, right? Treponema, staphylococcus. Virus like mumps, measles, hepatitis B, C, Epstein-Barr virus. Okay. Next is protozoa. Next is parasite. Then you have fungi. Okay. Non-microbial means it's not a parasite, it is not a bacteria, it is not a protozoa, it is not a virus. Non-bacterial, non-microbial is a foreign protein. It's a foreign protein. Okay, or it might be a toxin, or it might be a drugs. Okay, so it can be anti-tetanus serum, it can be heavy metals, or it can be a tetanus toxoid. Okay, drugs like gold, penicillamine, and captopril. Okay, now endogenous means we all know about the CNK PNK, that is anti-nuclear antibody, or it can be a thyroglobulin. Okay, histological classification, it can be divided into minimal change glomerulonephritis, focal segmental glomerulonephritis, PSG in post-cerebral glomerulonephritis, IgA nephropathy, Alport syndrome. Okay, so these all fall under hereditary nephritis. This all falls under nephritic syndrome. Okay, what are the clinical features? The patient presents with hypertension, oliguria. He presents with hypertension, oliguria, or it can be acute renal failure, signs of acute renal failure. So you might be presenting with uremic signs and symptoms. It might be a chronic renal failure secondary to, for example, there was a diabetes. Diabetes initially led to nephrotic syndrome, but there is now chronic fibrosis, and because of fibrosis there is damage that will lead to chronic glomerulonephritis. Okay, so chronic renal failure can happen because of diabetic nephropathy, isn't it? So it can lead to chronic renal failure. Okay, hypertension. Now if you talk about proteinuria, so it might be normal or it might be mild. Okay, proteinuria. Hematuria will be there. Hematuria means microscopic or microscopic. Microscopic means less than 5 per high power field. Microscopic proteinuria means you are able to see visual proteinuria. Okay, dysmorphic cells may be there, and RBC cast may be there. Dysmorphic cells and RBC cast may be present. Okay, now rapidly progressive glomerulonephritis, membranoproliferative glomerulonephritis, focal glomerulonephritis, IgA nephropathy, systemic diseases like SLE, PAN, HSP, okay, infective endocarditis, Alport syndrome can also lead to acute nephritic syndrome. Okay, acute nephritic syndrome. Now, most important asked in the exam is how are you going to treat this condition? So, treatment most often it's asked regarding post-streptococcal glomerulonephritis. So, how are you going to manage this case? Management of post-streptococcal glomerulonephritis. So, how are you going to manage this case? So, number one, it's the food. Major treatment. Okay, it's not steroid. Okay, steroid can given to decrease the inflammatory process, and since we are not using steroids as a major treatment here, the major treatment would be go for bed rest. Okay, go for sodium control. Fluid intake is same as I told in nephrotic syndrome. 500 ml if edema is there, not exceeding more than 1000 ml. If there is no edema, if no edema is present, you can go for initial day urine output. Okay, plus 500 ml. Okay, next it's where you go for diuretics, fluid restriction, sodium restriction. Okay, less sodium. Go for ACE inhibitors. Now, if there is a hypertensive encephalopathy, go for nifedipine. So there can be a hypertensive urgency or emergency in this case. You have to treat it accordingly. Okay. Next thing, what are you going to investigate? So we are going in a retrograde fashion. Investigation, throat swab is important. Chest x-ray, same thing as you wrote, extra. Throat swab must be taken. Some history must be taken regarding any kind of upper respiratory tract infection 4 days back. History also must be taken. regarding heart conditions, just also look into echo. There might be features of rheumatic fever. Don't miss it out. Okay. So this completes your nephritic syndrome.